Our next speaker is Dr. Minghao Liu. She is the director of Friedman Transgender program in our division, and she will talk about the adult care, hormonal care of adult transgender patients. We may run 5 minutes or so late, but please feel free to zoom in and out, as this conference will be going on till 11:30.
Hi, good morning, everyone. Thank you for having me. So as Dr. Meacher mentioned, there's a sizable population of transgender patients in our country and in our state, and a critical healthcare gap. So hopefully after this talk, more people will feel comfortable in initiating and maintaining hormone therapy for adults. So the content for this talk derives from guidelines from the Endocrine Society and the World Professional Association for Transgender Health. And also Callan Lord has a very nice, easy to follow protocol for up-titrating, which is public on their website. So we'll talk about the workup before starting hormone therapy, the goals of hormone therapy, different formulations, timeline of physical changes after starting hormones, monitoring for adverse effects. So the Endocrine Society recommends that before starting hormone treatment, a mental health professional or a doctor trained in transgender care diagnose gender dysphoria, as defined by 6 months or more of incongruence between the expressed gender and the sex assigned at birth associated with significant distress, whether it be clinical, social, or legal. And this must be confirmed by the physician who is prescribing the hormones. As Dr. Su said, patients must be counseled regarding options for fertility prior to treatment with sex hormones, as this treatment may decrease fertility. In addition, medical conditions that can be affected by hormone therapy should be evaluated and addressed ahead of time. So these include a pre-existing condition of heart disease, stroke, breast cancer, liver disease, HIV, and mental health. And for those receiving a feminizing treatment, they should be inquired as to whether they have a history of prolactinoma, clotting, gallstones, or high triglycerides. And for those receiving a masculinizing treatment, they should be asked about a history of high blood pressure and uterine cancer. In addition, medical providers should also obtain a thorough family history, and also whether patients have used street hormones before, as this may sometimes happen. Also whether patients have substance use and smoking, and also their social support and living situation, as this will impact their adherence to treatment. The baseline blood work to be checked before starting hormones include a CBC, basic metabolic panel, liver function tests, fasting lipids, testosterone, and estradiol. In addition, for trans women, prolactin should be checked. The goals of hormone therapy, as Dr. Su mentioned, are to reduce hormone levels of the sex assigned at birth and thereby reduce secondary sex characteristics. For trans women, this includes decreasing erections, facial hair, and muscle mass. And for trans men, this means ceasing periods, decreasing hip fat, and breast tissue, although each individual's goals are different. In addition, the goal is to maintain hormones in the physiologic range of the affirmed gender. So first, we'll start with a feminizing hormone regimen. There's different formulations of estrogens. It comes in the form of oral estradiol pills, which can be started at 2 milligrams per day with a max dose of 6 milligrams per day. Estrogen is also available in terms of estradiol patches, which can be applied twice a week. In addition, estrogen can also be injected, and it's available as estradiol valerate or cypionate. This is injected intramuscularly every week or every 2 weeks. Next slide. So if you notice on the previous slide, all of the formulations of estrogen were estradiol, 17-beta estradiol, which is a bioidentical formulation. There is another formulation called ethinyl estradiol, which is used commonly in oral contraceptive pills and postmenopausal hormone replacement. However, this is associated with an increased risk of thromboembolic events and an increased risk of cardiovascular death, as seen in some of the older, larger cohort studies. So we do not use this in gender-affirming care. There's also a formulation of estrogens called conjugated equine estrogens, with the equine meaning that it's derived from pregnant mare's urine. This is a combination of weaker estrogens like estrone with brand names like Premarin, PMS conjugated estrogens, and Contrast. So these are not detected in commercial assays, and therefore we also do not use these in transgender care. One consideration is that treating with physiologic doses of estrogen is not enough to suppress testosterone into the normal range for cis women. After starting estrogen, testosterone decreases to about 200 to 300, whereas the normal testosterone level in cis women is less than 50 usually. Therefore, it's important to also concurrently give an androgen blocker with the goal of decreasing testosterone to below 50. The first-line agent in the United States is spironolactone, which inhibits the secretion of testosterone and also binding in androgen receptors. Cyproterone acetate is a steroid with progestin-like activity that suppresses gonadotropins, LH and FSH, and thereby decreases testosterone. It is used pretty widely in Europe, however, is not available in the United States. In terms of second-line agents, there are the 5-alpha reductase inhibitors, which include finasteride and dutasteride, which decrease the conversion of testosterone to dihydrotestosterone. These can worsen depression and therefore are second-line agents. In addition, flutamide is also an option. So this is a non-steroidal anti-androgen that causes increased production, continuous production of gonadotropins, and thereby decreases testosterone and estradiol. It can cause hepatotoxicity, and therefore it's also a second-line agent. And as Dr. Su mentioned, there's also GRNH agonists as androgen blockers. So these are incredibly potent and can be used if the ones previously mentioned do not suppress testosterone to goal. And they include leuprolide and goserelin, which can be injected every month or every 3 months. And the mechanism is by decreasing LH and FSH and thereby decreasing testosterone secretion from the testicles. So next I'd like to talk about the timeline of feminizing effects. So within the first 1 to 3 months after starting a feminizing regimen, people will experience a decrease in libido and a decrease in spontaneous erections. In the next 3 to 6 months, people will experience a decrease in muscle mass and strength, and also softening of the skin, a decrease in hair and oiliness of the skin. They'll also experience a redistribution of body fat from the abdomen into the breasts and the hips, which leads to breast growth, and also a decrease in testicular volume. And in the ensuing 6 to 12 months, terminal hair growth, which is the coarse dark hair that is exposed to androgen, will also decrease. In addition, sperm production will decrease, but the timeline to this is unknown, which is why it's also important to counsel on fertility prior to starting hormones. Of note, estrogens and anti-androgens will not cause scalp hair regrowth if this is something that runs in the family and if it's already happened to the patient, and it'll also not make the voice higher. In terms of monitoring, it's important to know that high levels of estrogen can lead to increased risk of clotting, liver dysfunction, and high blood pressure. Therefore, it's important to have an office visit every 3 months in the first year, and then 1 to 2 times a year thereafter, checking for signs of feminization, development of side effects, monitoring levels of testosterone and estradiol, and also potassium if the patient is on spironolactone. In addition, prolactin must also be monitored. So a special note on prolactin. Back one slide, please. Thank you. Estrogen can increase the growth of pituitary lactotroph cells, and indeed this is kind of what happens during pregnancy. So up to 1/5 of trans women on estrogens may have hyperprolactinemia, which is associated with pituitary gland enlargement or growth of adenoma. If this is observed and estrogen is discontinued or reduced, prolactin will usually normalize. We check prolactin at least once a year during transitioning and then every 2 years after. Next slide. Next, we'll talk about a masculinizing regimen. So the foundation of a masculinizing regimen is testosterone, and there's different formulations. In terms of the transdermal formulations, we have the gel, which is applied once a day. Special consideration for this is that the patient must avoid showering or skin-to-skin contact for at least 2 hours after application, because showering will rinse it off, and skin-to-skin contact has the complications of transference to intimate partners or to pets. There's also the daily testosterone patch, which does not have the issue of skin-to-skin transference. So the goal level of testosterone is the same for either of these formulations. It's 400 to 700, checked after it reaches steady state. And this is the mid-range of normal for cis men. Next slide. Testosterone can also be injected. The different types include testosterone enanthate or cypionate, which can be injected intramuscularly or subcutaneously once a week or once every 2 weeks. There's also an ultra-long-acting formulation of testosterone undecanoate, which is injected every 3 months into the muscle. Next slide. So recently, there's been new medications that have been FDA approved for hypogonadal cis men, including Xiasted, which is a subcutaneous weekly testosterone, and also Jatenzo, which is an oral testosterone. Currently, they're not widely used in transgender care, but may be an option for the future. Next slide. In terms of the timeline of masculinizing effects on testosterone, within the first 1 to 6 months, patients will experience skin oiliness and acne, and it's kind of like going through second puberty. They'll also have a decrease in fat and increase in muscle and redistribution of fat from the hips to the abdomen. Within the first 1 to 6 months, periods usually stop. Patients will also experience clitoral enlargement and tingling and atrophy of the vagina. So it's important to counsel regarding using lubricants if they're having sexual intercourse using that organ. In the next 6 to 12 months, patients will have an increase in facial and body hair growth, scalp hair loss, and increased muscle mass and strength. They'll also have a deepening of the voice, which is not reversible. Next slide. In terms of monitoring for trans men, they should have an office visit every 3 months in the first year, and then once or twice a year, looking for masculinizing changes, including increased hair, muscle growth, cessation of periods. In addition, blood levels of testosterone should be monitored every 3 months. In terms of the timeline for checking, for the gel or patch, it should be checked after at least a week of daily application and at least 2 hours after application. In terms of the weekly or once every 2 week injections of the enanthate or cypionate, it should be checked mid-cycle or halfway between injections. And for the undecanoate, it should be checked as a trough or before the next injection with a goal of above 400. Next slide. In addition, during these office visits, we should also be monitoring for adverse reactions, including a rise in hematocrit. So we try to keep the hematocrit to less than about 50 to 51%. If it reaches above that, there's 2 options, one of which is to decrease testosterone. The other one is therapeutic phlebotomy. In addition, we also monitor for transaminitis and liver dysfunction, high blood pressure, any incidence of stroke or heart attack, cancer of the breast or uterus, which is a theoretical possibility since testosterone can be converted to estradiol. And we also monitor the cholesterol profiles because in different studies, testosterone has been shown to increase LDL and triglycerides and decrease HDL. Thank you.